can only do their job if they're connected with veterans who are interested in taking advantage of free resources at the VA. And they're incredibly well trained, right? Many of them are clinicians. And one of the things that we're working on with Veterans Crisis Line is across the different veteran simulations, how would you, in an empowering way, identify that as an opportunity for the veteran who's calling, right? And there are better ways and worse ways of talking about the Suicide Prevention Coordinator program. And for any of us in our daily lives, we know there are better and worse ways of flagging resources for our friends, right? There's really prescriptive and disempowering ways, and there's really kind of empowering ways as well. And I think this is true across a wide range of VA mental health services. This is true about crisis intervention more broadly. So as we think about the immersive technologies and hyper-realistic training, it's not just in the specific vacuum of getting folks ready to talk to a veteran on Veterans Crisis Line on day one, but that are they set up to be a front door to all of the VA? Because even the Veterans Crisis Line, right, 2,000 total staff serving over 1 million interactions is an enormous investment. And we see immersive technologies as enhancing that investment.
So something I'm hearing from all of you is access and also human connection. So Sharon, I want to go back to you first. We'll go to human connection first. Tell me how you see either where the technology is right now or where you see potential moving forward. How does it enable? How does it empower? How does it equip people to connect to other people? What does that look like?
Yeah, that's a great question. I think the first place to start is defining what those barriers may be. There's stigma around even talking about having these thoughts or feelings. There's geographical barriers, there's physical barriers, there's just conflicts with work and the amount of time you have, right? And so I think it fits nicely into each of those spaces, but when we think about how it fits, we have to think about this technology as augmenting what already exists and taking the burden off of healthcare providers so that we're able to triage people that need intensive care and create space for them to have the one-on-one time they need with a clinician, while also providing access to care for those who have all of these other barriers that we've mentioned earlier. And I think it's only in combination that we're able to really move the dial.
There's a great TED Talk. I don't know if you guys have heard the one that says, if you want to help people, shut up and listen. And I think where you're getting at is really important. Is I may have my own assumptions about what the barriers are, what this, what the stigma or things, but how do we actually connect with the veteran and find out from their perspective, right?
Absolutely.
And then design the solution around that. Nick, how would you respond to that question?
Yeah, I mean, just so back to our model, we really lean into groups as a way to scale that access, but the immersive platform itself as a way to get folks in the door. Even though they have the ability to control over what they disclose, over time they build the trust with peers with lived experience and with either a professional moderator or a peer support specialist who's on the other receiving end. I think that's where we can continue to tackle the challenge, not just with suicide prevention, but broader just mental health access in general.
I think that makes a lot of sense. Sam, with yours and human connection, I think one of the things that being able to practice some of those conversations in a simulated environment, what would you say that builds in the clinical staff and the responding staff that is uniquely helpful?
Yeah, I think at its core, empathy is a skill, right? That you can get better at it. There is a big difference between, that sounds really hard and it makes total sense that you feel isolated when you're the only veteran in your town and you have no one to talk about what you went through with, right? So from the first moment you're on the phone with Veterans Crisis Line, if the responder can have a higher level of empathy, the connection is much deeper, right? And all of the evidence suggests that that deeper connection, and this is across all parts of psychology and therapeutic support, you're going to build a stronger connection. What's that going to do? You're going to be able to do a more accurate risk assessment. You're going to have a more empowering conversation about safety planning and resources. So when we think about empathy and human connection, it is a few of the AI-powered scoring dimensions that we use in the training. So when you do a simulation, you don't just interact with a simulated veteran, at the end of it, you also get very intuitive red, yellow, green scoring on how did you do across the suicide prevention coordinator part of the conversation, risk assessment, empathy, openness, the opening protocol. And what we see time and again is empathy is not uncorrelated with risk assessment. It's not uncorrelated with safety planning. So as we think about kind of the upskilling on that human connection piece, and also it's hard to do it on the phone or via text, right? You've never met this person in person. So being able to do it in a remote environment is a very specific type of skill that has huge payoff.
And it's interesting, the scaling part, right? How do you scale humans?
Yeah.
It's really hard to multiply individual people.
Yeah.
Nick, we'll go back to you. As we think about access, so certainly there is the opportunity if they're using Kibana, that's access, right? They have a new resource. Let's say they get to Kibana, they see benefit, they're plugged in, they're connected. Then what happens? Have we started to think about what the longer user journey looks like? Or if we haven't, then what would be your off-the-cuff thoughts?
Sure. So one of the things for us is also thinking that, how can we provide a service that's not just a point solution, not just peer support, but so like we're building in micro-learning, so to tackle self-reliance, as a veteran myself, wanting to solve the problem myself, and like, what can you do for me to like help me fix the problem, or so start to empower them with other types of resources, but then also think about how are we connecting in, not just with VA, but other veteran serving organizations, creating more channels for referral to plug into other resources, and then escalate if there are higher acuity needs, knowing that what we're doing is subclinical, being able to have those partnerships in place to hand folks off. So, yeah.
Yeah, I think it's true at Veterans Crisis Line as well, right? And again, we're talking about Veterans Crisis Line, but this is true across the crisis continuum, right? At different points on the continuum, there are different solutions that make more sense, and it's actually why it's really inspiring to be up here with you both, right? Because we're talking about the continuum, and I think in probably a more nuanced way in 2024 than it's ever been talked about before, and it deserves to be talked about in this nuanced way.
I think that's a great point. Thinking about it in an ecosystem, right? There's nothing in this conversation, though these are representing three different entities, right? There's nothing in this conversation that has felt like my solution versus your solution versus your solution. We're all here talking about how do we prevent suicide. And there's no greater mission, and we can't do it by ourselves. And so I think thinking about it collectively, because each of you plays an important role at different points in the journey. Sharon, do you want to add to that question?
Yeah, I'm just thinking about the entire Mission Daybreak experience, where it was a challenge and there were 1,300 applications, but every solution had value. And as suicide is a multifaceted issue, whenever we were demoing or a part of the incubator, we could see the value in everyone's solution and how each solution was a part of a larger ecosystem where we would tackle one piece of the larger pie, right? And they all fit together so nicely. I mean, even before we came up here, we were thinking, oh, you have such great content at Kibana that could fit into the ecosystem of Battle Buddy that we can push out to that specific population. And it's just such a natural fit, right?
That's it.
Yeah.
I love that concept. We've talked some about community of communities, right? How do we build that kind of approach to how we think about this?
Yeah, I think you said earlier, Ann, that the best way to help someone is to listen, right? Or the best way is maybe start by listening.
Yeah, exactly.
And one of the things that we actually did at the Mission Daybreak kind of convening where all the judging was occurring was actually ask other teams, here's what we're doing. What of your expertise could apply to what we're doing? And one of the conversations we had was Casey Woods from Just Fucking Ask, the campaign, and a lot of the research and work that she has done informed our simulations on mean safety, and in particular firearm safety. And I don't think if we had not been in that room with Casey at that point in the development process, I think it's a genuine open question. Would we have found her? Would we have found her expertise? And could we have brought that into the Reflex tool? So, we talk a lot about our collaboration within the VA with VA experts, but there's a lot of kind of invisible expertise, I think that flows across the tools. And being in the room right today with you all, you will probably hear me ask more, what's on your mind that Reflex should know, versus let me tell you what's on mine, because what's on your mind is actually more likely to be helpful than what's on mine.
That's good. Okay, so suicide prevention is a complex problem, which I think is an understatement, with a multitude of risk and protective factors that affect every individual differently, and the unique nature of the veteran experience can often make veterans particularly vulnerable. To be effective, suicide prevention solutions must meet individuals where they are, which is where we were all getting to, rather than a one-size-fits-all approach. How did each of you develop your solutions with the needs of veterans in mind? Sharon, I'll have you go first.
Yeah, we listened, honestly. We had run many user studies in order to be able to rapidly iterate with feedback from veterans in real time. And then with the support of the funding through Mission Daybreak, we were able to bring veterans onto our staff across multiple branches of the military who helped us form the persona of our virtual character. Because authenticity is key to having any sort of rapport with our end users. And so you go through this process of listening, building, correcting, course correcting once you get feedback, and that process certainly doesn't end. And the other piece is that, aligned with meeting other people who had innovative solutions, the venues and events we've been invited to have introduced us to members of the VA and veterans who are working with the VA and 2-year technical programs that are so eager to help us shape our solutions, and we have the space and the ability to listen to them because of Mission Daybreak. So that's been wonderful. Yeah.
That's awesome. So not just listening, but actually doing something with what you hear.
Yeah.
It's really important. Nick, do you want to add to that?
Sure. A couple of ways. So we were fortunate to be able to build the initial platform with the Air Force, so they already had a military audience in mind. But also, recognizing that we don't all have VR headsets in our back pockets yet. Yet. Let's get after it. But wanting to be platform agnostic. So having it work in VR headsets, but also web and mobile access. But also through Mission Daybreak and a lot of the partnerships, and just being able to connect with other community partners, Staff Sergeant Fox grantees, state agencies, and we're excited to work with now the Commonwealth of Virginia and getting veteran peer mentors on the platform as professional moderators and getting their feedback for product design. So getting both ends on the user experience of the veteran, but also of the provider peer in terms of making improvements. So,
yeah. At its core, simulation is hard, right? And nuanced simulation is harder, and nuanced simulation for a diverse community is even harder. And in the context of veterans, emotional valence is really important. There's a difference between someone who's angry or frustrated. There's a difference between someone who's scared and uncertain. There's a difference between someone who's sad and uncertain versus someone who's sad and frustrated. And so as we thought about meeting veterans where they are, right, it meant first and foremost being able to really understand this complexity, both on the demographics, the lived experiences, the emotional valence, and building that into 8 different simulations in hundreds of different ways that's going to show up differently depending on how each trainee, who's also an individual person building their skills in a unique way, is going to interact with it. So I think for us, keeping the needs of veterans in mind meant kind of putting ourselves in the heads of different veterans in a really structured and complex way, and then also putting ourselves in the heads, to the extent you can do this, right? Putting yourself in the mindset of the trainees at different points in training with different skills and different lived experiences, and then putting that all together in a simulation that's going to provide genuinely challenging practice that prepares them for the shared goal of readiness on day one.
That makes a lot of sense. I'm going to introduce a term that we haven't talked about as much as you probably hear in your normal day-to-day life, but I've certainly heard it referenced a few times, artificial intelligence. Certainly people conflate the terms sometimes when we're talking about immersive. They switch to talking about AI or AI. Maybe they talk about immersive sometimes. But I do think there is critical intersection and connection between the two. So would love to hear from each of your solutions, how are you incorporating or thinking about incorporating AI? And the other side of that being, how are you planning for mitigating the risks or concerns that people may have around it? Nick, do you want to go first?
Sure. I'll start on the risk side. So, we're fundamentally about, pushing towards social connection and protecting privacy and trust, with the veteran or the user. But so many other avenues and opportunities for us to leverage that into our platform. So we talked about the micro-learning, creating journeys, enhancing the user experience. So, I'm typing in lost my dad. So how can you, instead of, traditional search, how does that recommend you toward a specific group or a piece of content, and sort of getting the individual to what they're looking for faster and improving that speed to support. So excited where that can continue to grow.
Sure. So I've sort of 3 ideas about this. AI doesn't sleep, which is fantastic. We're able to leverage it. It's definitely a force multiplier for anything that we're trying to achieve. But I think at this moment in time, AI should be considered a collaborative tool. And so when we think about how we implement it into Battle Buddy, we use it in a lot of ways to speed up content production, when we think about the backgrounds we choose or using LLMs to generate scripts, but that's never independent of a human in the loop. So it's always vetted because this is an extremely sensitive population that we're working with. So while we're excited about it, we're still not ready to let it off the leash. Yeah.
As in our name, right? That what we do would be impossible without AI. So maybe I'll just build on that. As Sharon said, human in the loop. I think for us, having AI so core to what we do, there's also a question of which humans are in the loop and how are you looping them in, right? And for us, that meant as part of developing simulations, we also do a veteran peer support training that we offer for free. But as we were developing that as well, it meant involving over 500 veterans. And because human in the loop is not just leaders in the loop, but it's the veterans in the loop, right? So asking them, are these simulations realistic? Are they representing lived experiences that you have? Are they using the vernacular you're using day to day with your buddies? And having a diverse and inclusive process for doing that. One other piece on this, I think part of human in the loop is the how you're getting them in the loop. So for some folks, that means taking an anonymous survey. For some, that means being part of a focus group. For some, that means a one-on-one interview, in person or digitally. So I would really just encourage everyone here, when you hear the term human in the loop, therefore, we are mitigating the AI risk. The follow-up question of, can you tell me more about that, tends to actually tell you, should you be satisfied with the human in the loop that is being codified, right? And I think, Sharon, as you were laying out, right, the different ways that you're using AI, right? It's great that it can write a script. Is a human scrutinizing that script as closely as they would a script that a human has written, right? And I think there's a lot of nuance to human in the loop that I think we're approaching, but is certainly more inconsistent than it should be in the years ahead.
I think that makes sense. So I'll ask you a question about timeline in just a second, but after this question, would love for any of you, 1 or 2, 3 people, to respond with questions or something that may have been mentioned today that you're curious to learn more about, or sort of made you lean forward or lean in a little bit, so we can give the panelists an opportunity to respond. But so if I remember correctly, 1,300 entrance applicants. I was sort of a judge in the process, so I vaguely remember this timeline over multiple years and a lot of.
Thank you for your impeccable taste then.
Well, yes, absolutely. So I will tell you that what I remember is November, I believe, there was a demo day, which for those of you who heard Dr. Kirsch speak this morning, that was actually the picture that was up. She was demoing Oxford at the time, then acquired by Behavior, now Realize Care, who is also here and a Mission Daybreak winner. So that was November. Everybody sort of got to demo, and then we selected the winners in February. So since February of 2023, what progress has been made? What sort of advancements? Where are you guys now, basically, as opposed to where you were when this first was all finalized?
Right, I'll take it. Since then, a lot of interest, particularly with two VISNs in our project. Obviously, survivors of suicide attempts is a very specific population, and so having to build partnerships with not just one site but many to think about that. It's also a research study, which adds another layer of complexity with IRBs and on top of that. And so we're building those partnerships, but at the same time working outside and with established VA partners, VSOs, starting to build those connections, a few academic partners as well. So starting to run groups that are non-clinical for us to have that ability to have a recruiting pipeline into the study. So excited where it's heading. Thanks.
Yeah, so we entered the competition with an idea. And since then, we've been so pleased with our progress. In the keynote, you've seen some of it, to have a working prototype that we can test with veterans. This summer, we'll do more extensive user testing, but I think now the time is ripe to partner with commercial entities that can help bring this to market. Because we don't want it to be in a lab. We don't want it to be in a perpetual stage of iteration. We want to get this to the hands of veterans. And the way that we do that is by partnering with academia, the VA, and also outside commercial partners through licensing. So we're super excited about these next steps. Yeah.
And one of the fun things about being here this week versus any other is we're in full-scale implementation with Veterans Crisis Line. So the first training class just completed. 43 trainees completed. Last time I checked, 408 simulation runs. And the next class starts next Monday. And then we'll be doing, I think that's another 60 or 70 people. Then over the summer, there's an in-service training for about 1,200 current VCL responders who will probably do another 4,000 to 5,000 simulation runs. So I think I'm very grateful to the VA for saying, we saw that you did this before, now do it, right? But execute, right? Or deploy, and we're in full deployment. I think there's still learning to do, there's still growth and enhancement to do, but Sharon said the joy is getting it in the hands of users, right? We don't want it to just be under development forever, and based on the contract timeline, we made sure that was the case.
I love it. So as you can see, very different stages of the innovation to implementation lifecycle. Certainly learning, we've been learning, I know, along the way, as I'm sure you all have been as well. So thanks for being with us on the journey. We're excited to see this continue to grow and move to implementation. Do we have one or two questions? We have about 5 minutes. Would love, if not, I have a question for them. So it's either you guys ask questions or I give them another one. So we got one over here. Okay, great.
Hi, I'm Caitlin O'Connor. A quick question. I heard you mention at the beginning of the panel that adoption isn't necessarily as much of a challenge as sustained engagement is. Have you all learned, and I think that's probably a challenge for a lot of different populations in digital health, have you all learned anything specific to the veteran population that is successful in helping build sustained engagement?
So we have a long history of research with virtual humans. There aren't as many longitudinal studies as we would like, but the evidence points to the fact that if you personalize an engagement, if there's a persistence of memory, so the virtual human knows something about you and brings that to the next interaction that you have, and if the content that it delivers to you is something that is high value to you, you're more likely to continue to come back to that interaction. So that was sort of the base rationale for incorporating a virtual human concierge. Yeah.
This is not my anecdote, so I'm going to give third person credit on it. One of the clinicians I talked to as we were starting Reflex was asking, do you know what determines whether or not someone shows up for their second or third appointment with their therapist? So I thought I had a great answer around how empathetic is the therapist, right? Do they click? And it turns out one of the biggest correlations is there enough spots in the parking lot? And how nice is the waiting room? And I was taken aback. Why is this the case? Because it's really hard to know whether or not therapy is working in the first hour. So one of the proxies for quality is, what is my access, right? Is it easy to show up at the appointment? Do I walk in feeling frazzled, or do I walk in feeling chill because there was plenty of spaces and I wasn't worried about wedging my car in, right? So as we think about adoption, you can get people to show up on day one, and you can be the world's best therapist. But if it's a total nightmare to parallel park on the side street, someone's going to a different therapist, right? And that's on you as the therapist, it's not on them, right? And part of that is you need to set expectations. Part of that is you need to be clear about the why behind these things, but it's different than you would expect. And I think as we think about new technology, that's the surprising moment, right? Is what's adoption, but then what's the utilization curve? And it can't just be, well, we have a great product, people are going to keep using it. You have to actually put yourself from their perspective and ask them and look at the studies on what truly drives sustained engagement, because sustained engagement is what leads to results.
Yeah, I'll add just, we're getting great engagement with other partners of ours in the healthcare sector, and as we start to ramp up to bring more veteran and military users, like that's the big question. And so continuously trying to learn and understand what's bringing folks back, but also to the point of the big question of as a veteran, certainly there are unique experiences that I had, my contemporaries had. How much do we need to tailor or customize that content to them, or not? Just recognizing that we're also humans, and so we have challenges at home, challenges in the workplace. How much needs to be tweaked or tailored to really resonate with that user and bring them back? That's why we pilot.
Hi, I'm Jake Earl with VA's National Center for Ethics in Healthcare. This is enlightening. It's so good to hear from all of you. I was wondering if any of you could comment on how you're approaching measuring the effectiveness of these different interventions. They're all evidence-based. You're in different stages of implementation, but how do you know that it's working when you're ready to test whether it's working? Thank you.
I'll jump in. So we've just stood up 2 academic partnerships, one with Syracuse University, another with Tulane School of Social Work. One is building academic partnerships to do the longer term, evidence based around taking evidence-based approaches, but in a different modality. And of course, our Mission Daybreak project is also by itself a research study, so building evidence within that specific subgroup. But also within the platform, building in advanced screeners. We already do quality, self-reported type screeners and utilization, but adding PHQ, GAD, other types of measures for the right, in the context of the right partner, the types of groups that we need. So that's, I don't know, other thoughts?
Yeah, that's aligned very much with what we're doing. There's subjective report, right? We can ask people, do you actually like this? And that's a great place to start. but then we can also track people over time with more objective measures, and that can be how long they're engaging with the application, what parts of the application they're actually engaging with, and then as you mentioned, standardized questionnaires that can chart their depression or anxiety scores over time really are the categories that we're thinking about measuring in the first round.
All good.
All right. Well, thank you so much. We get a round of applause for our panelists.